Hello all, welcome to the YouTube channel of Sri Swaminarayan Physiotherapy College. Myself Dr. Khyati Mewada, lecturer at Sri Swaminarayan Physiotherapy College, and today I am going to discuss the common gait deviations in the human gait. Gait deviations can occur for three reasons. First, because of the pathology or injury in a specific joint. Second, as compensations for the injury or pathology in the other joints on the same side, or as compensations for the injury on the opposite side. Discussing the common gait deviations, the first one is the antalgic gait or the painful gait. It is a self-protective mechanism which results from injury to the any joint of the involved extremity. The stance phase on the affected leg is shorter. The swing phase on the unaffected leg will be reduced. Result in the shorter step length on the uninvolved side, reduced walking velocity and reduction of the cadence. The next is the ataxic gait, which is seen in cerebellar ataxia or the sensory ataxia, resulting from the incoordination. The patient might have poor sensation or lack of muscle coordination. Due to the poor balance, the patient will demonstrate the broad base of support. In the cerebellar ataxia, there could be lurching or staggering gait, and movements will be exaggerated, also known as a drunkard gait. In sensory ataxia, due to the impaired sensation, the feet will slap the ground because patient cannot feel, and the patient may also watch the foot while walking. Next is Equinus gait or toe walking. This is seen with patients with talipes equinovarus or clubfoot. Stance phase weight bearing is primarily on the dorsolateral or the lateral edge of the foot. Stance phase on the affected limb will be reduced and lymph will be present. The femur and pelvis will be laterally rotated on the affected limb. Next is the gluteus maximus gait. If the gluteus maximus muscle of the stance limb will be weak during heel strike or initial contact when there is need of the hip extension, to compensate this need, the patient's trunk will lurch backwards. Next is the gluteus medius or Trendelenburg gait, which results from the weakness of the hip abductor muscles on the stance limb. During stance phase, when the pelvic stabilization is lost due to the gluteus medius weakness, the patient may demonstrate either dropping of the pelvis on the opposite side or lateral tilting of the trunk on the affected side to maintain the COG over the stance limb. If it is unilateral, it is known as the Trendelenburg sign. If it is bilateral, it will result in a wobbling gait. Next is the hemiplegic or the hemiparetic gait, which is classically known as the circumductory gait. The patient swings the paraplegic leg outward and ahead in circle or pushes it ahead. This is due to spasticity in the lower extremity muscles, which make it difficult for the patient to clear the foot during swing phase. Patient hikes the hip and bridges the affected leg by making a half circle known as a circumductory gait. Step length is lengthened on the involved side. In addition to this, the affected upper extremity is carried across the trunk for the balance. Next is the Parkinsonian gait, commonly seen in the Parkinson's disease. This gait is characterized by the shuffling or short rapid steps, also known as the shuffling gait. The arms are held stiffly and does not move with normal associative movement. Fascinating gait is also another name for this gait, as the patient may lean forward and walk progressively faster as though unable to stop. Next, we have the plantar flexor gait, which occurs due to the weakness of the plantar flexors of the ankle. It results in decrease or absence of the push-off phase at the ankle. The stance phase is reduced and there would be shorter step length on the unaffected side. Next is the quadriceps avoidance gait, occurring when there is weakness of the quadriceps muscle on the affected extremity. If the quadriceps muscle is injured due to any of the reasons, the patient's trunk and the lower leg will try to compensate for it. There would be forward flexion of the trunk combined with the strong ankle plantar flexion movement, causing knee to hyperextend. If for any reason patients trunk or leg cannot compensate for this, patient may use hand to extend the knee. Scissors gait. This gait is resulting from the spasticity of the adductor muscles of the hip, which causes the knee to drawn inward during walking. Short leg gait. This results due to the limb length discrepancy. Lateral shift to the affected side will occur and the pelvic will be tilted downwards on the affected side, creating a limp. Affected side means the shorter side. May also supinate the foot on the affected side to try to lengthen the limb. The joints of the lower limb may demonstrate exaggerated flexion or hiking of the hip may occur during the swing phase to allow the foot to clear the ground. Lastly, we have the steppage or drop foot gait, which results from the weakness of the ankle dorsiflexor muscles. Dorsiflexor weakness results in the foot drop. During gait, to compensate this foot drop and to avoid dragging the toes against the ground, the patient might compensate it by lifting the knees, that is flexing the knees higher than the normal, and during the initial contact the foot will slap on the ground due to the loss of control of the dorsiflexor muscles.